Great. Thank you very much. Thanks for having me here to talk about a subject that I think gets a lot of us a little bit sort of angsty. A lot of us don't really like to talk about dizziness, but it's now become a little bit of a passion of mine, so I hope to share a little bit of that with you guys here. And I apologize, I did watch the Super Bowl yesterday, and I also had kids that were up all night last night, so I'm going to try to get through this as well as everybody else. Okay. So I don't have any relevant disclosures, and these are my objectives for the talk. Which is basically to contrast presbystasis, which we'll talk about here today, with other disorders of balance, to describe a few different presentations of dizziness, and we'll get into the details of that, and then try to arm you guys with ways of diagnosing specific causes of dizziness, which will let you treat them in specific ways as well. So we'll try to get through all of that today in an hour. We'll see how we do. So, talking about dizziness in the elderly, number one, it's very common. So if you look at people about 60 years old, there's a 20% prevalence of dizziness of any cause, and if you go over 80 years old, that jumps up to 50%. So certainly a very common problem. You guys are probably all very aware of that. What's interesting is that the pathology in dizziness is probably similar to younger patients. So the same kind of things that happen in younger patients happen in the elderly. But the symptoms are usually due to an interaction between aging and the pathology that's present as well. So we kind of have to understand a bit of both of those things before we can go ahead and start treating dizziness in the elderly. So a little bit of physiology, not a ton of it on here, but we've got to do some. So this is sort of a generalized schematic kind of accepted about what plays into our balance system. So we have three main inputs to the balance system. There's visual, which is your vision, vestibular, which is the inner ear and vestibular sense, and proprioceptive, which is your peripheral nerves that are feeding in. And all of those things input into an internal representation of where you are in space and also how you're moving in space. And based on that computation of internal representation, you can then go out and perceive that you're moving. You have certain eye movements in response to movement, body movements as well, and sometimes autonomic activation, things like nausea and things like that. So this is the physiology of balance. And now I'm going to talk a little bit about presbystasis. And what presbystasis means is the normal aging process and how it affects our balance system. So what happens with normal aging? Well, in the vestibular system, we know that there are a decreased number of hair cells, which are the vestibular sensors, and there's decreased neural afferents. So the actual vestibular nerve, there's a decreased number of those as well over time. In terms of vision, we know visual acuity does decrease with age, and as well depth perception, which is sort of takes visual acuity into account, that also decreases with age as well. In terms of the proprioceptive sense, we know vibration sense and joint position sense also naturally decrease with age. And then if you look in terms of the internal representation, how we compute that internal representation of orientation, we know that in the CNS, in the brain, neuron density decreases over time, both cerebellar and in the vestibular cortex as well. And then finally, on the output side of things, we know smooth pursuit also slows down with age. Muscle bulk is not the same as it is when we're younger. So already you can see there's a lot of things that play into how balance naturally decreases over time with age. Then you can throw on top of it pathology. So what kind of pathologies can happen? And just to throw some common ones in there, in terms of vestibular, there's certainly vestibular insults like vestibular neuritis, which can affect the vestibular system with age. There's things like macular degeneration and cataracts, which can affect vision. There's neuropathies, which can affect the proprioceptive sense. Of course, there's things like stroke that can affect the cerebellum or the vestibular cortex. So when you look at this whole thing, it's all kind of red here. So you can see why, perhaps that's why dizziness is so common as people get older. There's certainly a lot of things that can play into damaging each portion of the balance system, and then when you add them all together, it's not surprising that a lot of older people have some difficulty with balance. Now, so that's presbystasis, a little bit of pathology that goes along with it. What I want to speak on is just a couple of words on medications. I'm not going to speak in detail about this because you guys are all experts in knowing that medications can certainly contribute, and certainly polypharmacy is an issue in the older population. So what I'll say on it is that apart from vestibular pathology, which is what we're going to focus on today, the leading cause of dizziness in the elderly is likely medications. So we always have to keep that in mind. We have somebody who's coming in dizzy, who's on a lot of medications. We have to look at them and look at all the medications in detail to see if we can get rid of any of those medications. And of course, there's lots of mechanisms for that. Orthostasis is a big one in terms of antihypertensive, but some other medications that are not specifically targeted, like antidepressants, dopaminergic meds, they can also cause orthostasis. CNS depression, of course, is a big part of it with AEDs and benzodiazepines, hypnotics, all these medications. And then cardiac arrhythmia is also possible as well, although this is less common. So certainly a lot of medications that can contribute. Okay, so we've covered a couple of things here, and basically here what I want to do is introduce my approach to dizziness in the elderly. It's not, it's sort of something that most people in the vestibular community would sort of grab a similar approach. But what we want to do, number one, is understand the contribution of presbystasis, and that's what we talked about earlier, how presbystasis impacts different aspects of the balance system, so we've done that. And of course, we want to review medications, and again, I'm not going to speak in more detail about that today. But what we want to focus most of our time on today is how to determine if there's any balance pathology present. And so what we're going to look at is, can we identify pathology in specific areas? Mostly we're going to spend time today on the vestibular system, which is my area of interest. Visually, it's important to get vision assessed in elderly patients to make sure that they've optimized their vision. And again, in terms of neurologic, we're not going to deal with things like stroke, but we should always keep that in mind that stroke and peripheral neuropathies can affect balance as well. So, now we're going to take a step back and talk a bit about dizziness and how do we approach dizziness when we're in there in the clinic. And so classically, when I went through residency and medical school, what I was taught is somebody comes in, they say, "Doctor, I'm feeling dizzy." The next question out of your mouth is, "What do you mean dizzy?" And you have to sort of, if you have a beard, it helps because you look a little bit more like you're smarter that way. So when they say, "What do you mean dizzy?" And then the patient has to come up with what kind of dizziness they have. And classically, if they said, "I have presyncope, I feel lightheaded," then that meant it's either hypotension or cardiac as the cause. And if they said, "Oh, I'm spinning," well, that means it's vestibular. And if they said, "I'm just kind of off balance," then that was neurological. And if they said, "I'm just kind of dizzy, I don't know, I'm just dizzy," then that was psychiatric or metabolic or something like that, right? So classic approach was this. And this has been ingrained in the textbooks. When you read textbooks on dizziness, this is the approach that was there. But if you take a critical look at that, what it requires, this kind of diagnostic strategy, is that, number one, patients can reliably differentiate the different types of dizziness. It also requires that patients can only have one type of dizziness. So if they say, "Well, I was a bit lightheaded and then I spun," you say, no, I need one. Tell me one so I can go down my path, right? So that's not always the case. And it also requires that the subtype of dizziness, whether you said lightheaded or spinning, vertigo, that it truly correlates with a subset of diagnoses if you're going to follow that pathway. And it turns out none of those are actually correct. If you interview people for dizziness and you ask them to say, "Well, describe your dizziness to me," and then you go back to them several hours later and you ask them again, 50% will change what they said. So they'll give you a completely different subtype of dizziness. So that doesn't help at all. Obviously, we're not getting at the right issue. And why is this important? Well, in one study, this was of emergency physicians, up to 70% of physicians in the eMERGE stopped pursuing other diagnoses based on what the patient said in terms of, "I was spinning" or "I was lightheaded," and they didn't explore other possibilities. And that can be a problem because we basically limit ourselves to what diagnoses we can make. Okay, this is the other problem that I find if you ask patients this. I still ask the question because it's interesting what people say, but here's some answers from patients. "Yes, like your head's becoming empty." I'm not sure, is that psychiatric, is that presyncope? I'm not sure, I don't know where to put that one. Here's another one. Patients have trouble, right? I think the general kneeling would be to the point where that woozy feeling, now I don't know how you want to describe the adjective, maybe woozy. So again, patients don't really know what you want when you're asking that question either. It's kind of like saying, "What do you mean chest pain?" I guess you could say, well, you can get tearing chest pain, maybe that's more dissection, maybe if you have more chest pressure, that's more cardiac, but even there, those things aren't as helpful. So we should really use the same approach to dizziness as we use for other complaints that we talk about in medicine. And this is especially true for older patients. symptoms are often more vague. So often, like even less than somebody who's coming in who's younger, who can describe their symptoms very well. As you get older, there's lots of reasons for this, but the descriptions often become more vague and it's more difficult to use that approach as well. So what should we do? Well, maybe we should change our approach and do what we do for all other areas of medicine. We don't always ask, what do you mean this, what do you mean that in other areas of medicine. We, let's say for chest pain, talk about what comes with it. So if you have chest pain, what you want to know is, did it come with a fever or cough? Was there leg pain or swelling? Was there hemoptysis with it? Did it come on all the time, or is it intermittent? Are there any triggers for it? Did it come on after you ate? Was it more with exertion or when you moved your chest wall? These are really important things that help us differentiate. And of course, you want to put your exam in there, like are there crackles in the right middle lobe, or do they have unilateral decreased breath sounds and a deviated trachea, to tell you sort of what the underlying etiology is. And of course, there's other testing you can do as well. So you can do chest x-ray and things like that for chest pain. So it turns out if you apply that strategy to dizziness, you get much more consistent responses from patients. They tell you the same thing every time, especially in acute scenarios and especially in the elderly. And the two most important things that come with it are what the timing is of the dizziness and what the triggers are for it. So what I mean by timing is it a single episode of dizziness? I was fine, now I got really dizzy and I'm kind of getting better. So that's called the acute vestibular syndrome. You get really dizzy and then you slowly improve over time. Is it multiple episodes of dizziness and being well in between? So again, normal, I got dizzy, I got better again, then I got dizzy again, then I got better again. So that's a different type of presentation, different etiologies behind that. Or is it what's called the chronic vestibular syndrome, where there's chronic vestibular symptoms that are present over an extended period of time? And it turns out these three syndromes actually do correlate a little better with subsets of diagnoses that we can make and then hopefully treat. The next important thing is to talk about triggers. And what I mean by triggers is that it actually has to be a true trigger. So if somebody's dizzy and then you move them around, they will be more dizzy, bar none. But what you want to know is if they weren't dizzy at all and then you do something, usually positional, and then they become dizzy, that's a true trigger. So from no symptoms to having symptoms is a trigger. From symptoms to more symptoms is an exacerbation, and that happens in most types of dizziness with head motion. The other thing is exposures. So obviously trauma, if they've been exposed to gentamicin therapy, these are things that would be considered triggers, but more exposures to things. All right. So for dizziness, our associations, timing, triggers are a little bit different than they are for chest pain. So for dizziness, we want to know, is there something going on in the ear as well? So hearing loss. Is there something going on in the head in terms of headache, neck pain? We want to know about chest pain because of hypotension being a possible cause for dizziness, et cetera, et cetera. We talked about timing and triggers already. And then in dizziness, we have different exam signs. So we have things like nystagmus and skew deviations and head impulse testing, Dix-Hallpike. We're going to talk about all these in terms of how you can apply them, but these are the tools that we have in dizziness to try to sort out what's going on. And then the testing depends on what you find, obviously, in the other previous steps. Okay, so let's try it. This is our approach now to dizziness. First, we're going to try it in non-dizziness, just to get everybody ready, and then we're going to go to dizziness. Okay, so we have a 68-year-old woman with tearing and ripping chest and back pain. So again, if you just took that and you said, what's the diagnosis here, which is what we did in dizziness all the time, what would the diagnosis be? Anybody shout it out? So most of us, when we're taught this, we say aortic dissection, tearing, ripping, chest and back pain, right? Aortic dissection until proven otherwise. Okay, but now if we ask a few more questions, it actually came on and worsened over several days. There's a productive cough associated with it. There's fever and unilateral crackles, and there's right middle lobe consolidation on the chest x-ray. So now, nobody out there would say this is aortic dissection. We would say this is a pneumonia, right? And I use this example because my wife, she's not 68, but she said exactly this presentation with her pneumonia. Tearing, ripping, chest and back pain is how she presented. So just a good example of how just the character of the symptoms is not enough. We have to go a little bit deeper. Okay, so let's try it with dizziness. So here we go. 78-year-old man with recurrent vertigo. My head is spinning for several seconds. So again, classically, if we were going to say recurrent vertigo lasting seconds, we would say BPPV. This is a classic story for BPPV. But if we ask more questions, actually this has been recurrent for weeks, but the triggers are exercise, going upstairs, and he has a bit of associated chest pain with it. And when you examine him, he has a delayed carotid pulse, and he has a murmur that even a neuro-otologist can hear. So if you put all of that together, This is no longer BPPV, but this is aortic stenosis, okay, as a cause of recurrent triggered dizziness. Okay, one more. 78-year-old man again, but now he has recurrent lightheadedness for seconds when he gets up from bed. Again, classically, dizziness getting up from bed. This is postural hypotension or orthostasis, whatever you want to call it. But again, if we ask a few more questions, again, it's been recurrent for months, but the triggers here are standing, but also bending over and rolling over in bed. And when you examine him and do a Dix-Hallpike maneuver, you see a delayed upbeat and torsional nystagmus. And also you check and make sure and there's no postural blood pressure drop or heart rate rise when he gets up. So now this is no longer postural hypotension, but instead BPPV. And the clear thing here was what the triggers were. It wasn't just getting up, but it was also other things that were triggering it. And then you went on and did the examination maneuvers to find out what the cause was. Okay, so this is the approach that we use when we do history taking and examinations in dizziness. And just some practical tips after having done this for a long time. I told you that really it doesn't matter what they say when you say, what do you mean dizzy? But it turns out that external vertigo, so that when the patient tells you the whole room was spinning around me, not I was spinning, but the whole room was spinning around me, I saw it moving, that usually means there's a problem in the vestibular system. The reverse isn't true though. So people could say that they are lightheaded, people could say that they are, they're just a bit woozy, and it could be a vestibular problem. So that doesn't help. But if they actually say the room was spinning, I saw it moving, that's much more consistent to be a vestibular problem. But when I say vestibular, I want to make sure I say that it's not necessarily peripheral. I mean central or peripheral vestibular system. So that could still be stroke in that scenario. The other tip is when somebody hasn't had symptoms for very long and you're listening the duration of symptoms, be careful of people who have frequent episodes with an intervening feeling of feeling crummy. So this is common in BPPV. People will move, they'll get dizzy, they'll spin for about a minute, but then afterwards they feel awful. And it all depends on what their response is to motion stimuli. So if you're a motion sick person and you have BPPV, your symptoms are going to be way worse because once the spinning has stopped, you actually continue to feel dizzy and sort of lightheaded and nauseated. So it's helpful there to ask how long was the actual spinning? How long was that room spinning around for? And if they say about seconds, a minute, something like that, and then I felt awful afterwards, then that still could be compatible with BPPV. The other thing I ask is how would you feel if you just stayed perfectly still the whole time? And if they say, oh, I would be completely normal then that can help a little bit. For people who have long duration of symptoms, they're so used to their dizziness that they'll often just describe exacerbations instead of how they are all the time. And so for people who have long duration symptoms, I'll often ask, do you ever feel normal? Or how many days out of the month are you dizzy? And if they say every day, then you kind of think, well, maybe you're talking about this episodic thing that's bad sometimes, but if you feel bad all the time, maybe we're talking about a different pathology there. So that's important to try to separate things a little bit. And the final thing I'll say is if you want to figure out whether something's a gait problem or a sort of equilibrium problem, or if it's a vestibular cause, one of the nice questions I've asked is it your legs or your head? So when you're up, is it your legs that are giving you the trouble, or is it your head that's giving the trouble? And that can sometimes help a little bit in separating things. Again, none of these are 100%. We use this to sort of build our evidence. Okay. The other thing I found in speaking with older patients is histories are often a little bit more vague. There's reasons for that. There's memory difficulties that start happening as we get older. There's also something called the loss of percept. This is kind of interesting. This came out of a study where they did what's called VNGs, or video nystagmograms, and part of that is caloric testing, where you actually squirt cold water in one ear or the other, and it creates a nystagmus. And so most people, if you do that and you have this nystagmus going, will say, I feel the room is spinning. But in older patients, a large proportion of them just said they didn't have any symptoms, or they just said they were a little bit lightheaded. So even though this is a true vestibular, there's nystagmus going, their eyes are jumping and jerking around, they didn't actually perceive vertigo. So it's something interesting when you're taking histories to know that they may not feel vertigo, even the pathology is vestibular. And I can't believe I'm saying this as a neurologist, because we love taking histories, and certainly 90% of our diagnosis on history. But sometimes, if you're not getting anywhere with the history, you just have to stop and say, look, I'm going to look for any pathology that I can find, and so stop talking and examine and look for specific things. And we'll talk about how you do that. Okay, so we're going to go through a few of these syndromes and talk about what they mean, what the diagnostic possibilities are, and how we can sort them out. So the first one I'm going to talk to you guys about is the acute vestibular syndrome. So the acute vestibular syndrome, as we talked about, is an acute onset of dizziness, nausea, vomiting, and gait ataxia. So the symptoms kind of come on quickly, and they usually kind of resolve over days. All right. So here's a differential diagnosis. You're going to mark it all down, make sure you get all of these, and look for all of them. So it's pretty big. But what I like to look at here is what are the common causes? What are you going to see more than 1% that causes more than 1% of these cases? And really, it's just here. And if you look at this box, you can see that there are benign causes, of which MS is one. MS probably doesn't happen, or at least doesn't onset in the elderly population very often. And the other one is vestibular neuritis, which is a benign cause. And then if you look on the other side, it's really stroke. So if you're talking about common causes of the acute vestibular syndrome, what we really want to know is, do they have vestibular neuritis or do they have stroke? And it turns out there are ways we can look at that and sort that out. And so here's an approach. If you guys can see the acute vestibular syndrome here, we're not going to talk about post-exposure acute vestibular syndrome. These are usually obvious, like if they've had barotrauma or a blast or they took toxin or something, so we're not going to talk about that. But for the spontaneous ones, there's something here in the targeted history and examination called the hints. Hints peripheral, hints central. And so we're going to talk a little bit about that and how it helps us determine what the cause of the dizziness is. So if you don't get the hints, if you haven't heard of hints before, where have you been for the last 10 years? This is everywhere now. But what hints is a battery of tests that are designed to separate stroke from vestibular neuritis. That's all it's designed for. That's all you can use it for. And it stands for a few tests, 3 tests actually. Head impulse, HI, N for nystagmus, and TS for test of skew. And when you use these 3 tests in the correct group of patients, it turns out it is better than MRI at telling you whether you have a stroke or not. So this is, the gold standard was you wait 24 hours, you do an MRI, you look for little small tiny strokes, so that was the gold standard. Initial MRI can sometimes miss small strokes, and so these battery of tests was better than that early MRI at detecting the stroke than getting that early MRI done. So pretty good, 96.5% sensitive. Again, in the right population. So how do we apply this? How do we use this? Well, what you need is someone who comes in with the acute vestibular syndrome. So they're a bit ataxic, they're dizzy, they just came on, they didn't have this before. And, this is really important, they have to have nystagmus. If they don't have nystagmus, you can't use hints. So you have to use other tests and things like that. So this is quite important because I often see this getting applied when patients don't have nystagmus. The reason for that is if you have an acute vestibular insult, which is what this is trying to find. This is trying to find people who have vestibular neuritis. You will have nystagmus. If you have an acute vestibular neuritis, you will have nystagmus. So that's why that's part of this diagnostic algorithm. The other thing is you don't need to apply it if there's obvious signs of stroke. So if they come in and they're acutely dizzy and they're weak on one side, you don't need this. You know it's going to be stroke, right? So this is to apply to patients where you're not sure, they're coming in dizzy, there's no major focal neurologic findings, and you try to see, is this vestibular neuritis or is this stroke? And these are both common in the elderly population. So in order to understand things about the HINTS exam, I'm going to give you a very, very brief vestibular physiology lesson right now. So this is super brief. So this looks really complicated, but it's not. The vestibular system of the inner ears, one of the main things that it does is keeps our eyes stable when our head moves around. So if our head moves to the right, our eyes automatically move to the left. There's this complex wiring that goes through the vestibular nuclei to the different nuclei that control the eye movements. But the basic premise is you turn your head to the left, your eyes go right. You turn your head to the right, the eyes go left. So this is a very basic wired system, and we can use this to try to tell if there's a problem in that very basic reflex. So this is called the vestibulo-ocular reflex, and that's what we test with the head impulse test. So watch this. This is the head impulse test. So what we're looking at, so it's fast. This is a little bit too much. You don't have to go that far with a head impulse test. Only about 15 degrees is how far you have to move. But what I want you to watch for is normally, if you move the head quickly, the eye should stay locked on a target in the distance. If the vestibulo-ocular reflex is not working properly, when you move the head quickly in one direction, the eyes will follow the head, which they're not supposed to do, and then they're going to refixate. You'll see the eyes refixate on the target. So watch for that. You're going to look for the eyes refixating. I'll tell you when it happens. So he's going to move the head to the left. Refixation right there. refixation. None to that side. He's going to do it one more time to that side. No refixation. He's winding up a little bit. You don't have to wind up that much, but, and then another refixation. If you didn't believe me, look in slow motion. There's actually two of them. Watch. Refixation, and then another refixation. Okay? So that's the abnormal part of the head impulse test. And so we'll talk about that, but actually you want to see that refixation. And why do you want to see an abnormal head impulse test? Because if there's an abnormal head impulse test, it means there's a problem in that very basic reflex. And the problem in that very, very basic reflex is usually vestibular neuritis, which affects the vestibular nerve, which is part of that vestibulo-ocular reflex. So if somebody comes in acutely dizzy, you actually want them to have an abnormal head impulse test, which is kind of counterintuitive. You want it to be abnormal. Okay, so that's the head impulse test. Skew deviation, it's complex in terms of what causes it, but what you don't want to see when you do this test, when you cover one eye and the other, is the eyes going up and down. If the eyes go up and down, they refix. See, this one's going lower, this one's going higher, this one's going lower. You don't want to see that because that's a sign of a problem in the central nervous system and not a sign of a problem in the vestibular nerve for the most part. So that's called skew deviation. You guys saw his eyes were moving in as well. That doesn't matter. So everybody, a lot of people will have a little bit of refixation inwards or outwards. You don't care about that. You care about the eyes moving up and down. So if the eyes, when you're getting them to look at a target in the distance and you're covering one eye and the other, if they move up and down with that, that's a bad sign. So that's skew deviation. And then you're looking for something called vestibular nystagmus, which is this. So the eye, you can see, nystagmus, it's beating here towards the left. See that the eye is jerking towards the left. There's a slow deviation to the right. When he looks over to the right, it kind of goes away. And when he looks to the left, it gets a little bit worse. That's okay, as long as it's always beating towards the same side, and it's usually a bit horizontal and a little bit of torsion associated with it as well. So I'll show it to you one more time because it's important to recognize that one. So this one is we call it a left beating jerk nystagmus. So it's always beating to the left. You guys see that there, beating to the left. And then he's going to look over to the right, and it gets better, which is typical for vestibular nystagmus. It gets better when you look away from the fast phase, and when you look towards the fast phase, that jerk phase, it gets a little bit worse. So this is vestibular nystagmus. Okay? This is not vestibular nystagmus. So here it's beating to the left when you look to the left, and now it's beating to the right. Not good. This is also not good. So this is someone with a different type of nystagmus. This one's beating down. We don't want to see that either. This is another person with a weird type of nystagmus. You'll never see this one, it's super rare, but eyes are going back and forth a little bit. It's called seesaw nystagmus. And the bottom line here, don't worry about this, the bottom line is if you don't see vestibular nystagmus, then it's bad. So you want to see that vestibular type nystagmus. So here, we'll go back, we'll say, what does it all mean? There's 3 tests. So if you have a patient that comes in with the acute vestibular syndrome, doc, I'm dizzy, I've been dizzy for a day, and you look at them, they have nystagmus, then you do the 3 tests. And if they have all of an abnormal head impulse test, so the head impulse is abnormal, they have vestibular type nystagmus beating away from the side that was abnormal on the head impulse test, and they have no skew deviation, so you do this thing and they don't move up and down with their eyes, then that's vestibular neuritis. Reassure them, it's going to get better. You can treat them with symptomatic therapies, vestibular rehab therapy, and send them home. But if you have a patient with the acute vestibular syndrome and they have nystagmus, and so these are all, any one of these that is not reassuring is bad. So if they have a normal head impulse test, that's bad. Or if they have any nystagmus except for that direction fixed horizontal torsional nystagmus, or if they have a skew deviation, any one of those 3, you got to work them up for stroke, because that's a large possibility here that that's what's going to have happened. And then finally, if you have a patient with the acute vestibular syndrome and they don't have nystagmus, so no nystagmus, one thing I always tell people is to make sure there isn't any. And so what do I mean by that? Well, you can actually dampen nystagmus by looking at something and sort of focusing on it. You can slow the nystagmus down. So one of the things that I tell residents to do is to cover one eye and shine a pen light in the other eye, which basically gets rid of fixation. You can't look at anything that way. It has the advantage of showing the eyes a little bit better, and you can look to see if any nystagmus comes out that way. So that's a quick way of removing fixation and bringing out nystagmus. But if they don't have nystagmus, then you have to look for other causes, and this is where it's a bit of clinical judgment. You have to try to see what might be going on there. You can look for medical, psychiatric, neurologic causes at that point. Okay? Good, so we're gonna try it. So you guys have now seen what the HINTS exam is. So here's a 60-year-old woman presenting with 18 hours of vertigo, dizziness, nausea, vomiting, and unsteadiness on her feet. So this is the acute vestibular syndrome. There's no focal neurologic symptoms, and there's no change in medications, no exposures, nothing else you can find that might be the cause. So here's her exam. Anybody see nystagmus? Yes, good. I had one person say yes, good. So yeah, so there's a left beating nystagmus, so people agree? Yeah, left beating nystagmus. Goes away when she looks right, and when she looks back to the center, it's left beating. So now we're gonna do the head impulse test. Big refixation. Nothing there, nothing there. Keep looking at the target, keep looking at the target. Big refixation, one more time. Nothing on that side, and then big refixation, okay? So abnormal on the right, she has left beating nystagmus, and now we're gonna do the test for skew. And she has the nystagmus, but there's no up or down movement of the eyes. It's just sort of drifting over. So, diagnosis, right vestibular neuritis. And you can say, don't worry, it's gonna get better, plus or minus treatment with steroids, plus or minus treatment with Gravol and things like that, but she'll get better over weeks. Cool, all right. So now you know how to diagnose the acute vestibular syndrome. The other thing I'll mention about medical causes of the acute vestibular syndrome, which they do happen, always have to look for different drugs. If they started a drug recently, if they were exposed to anything, if there's carbon monoxide and things like that that can make you dizzy. Obviously, any CNS medication can have a side effect, and there's all these other medical abnormalities. So usually, from the associated symptoms that are coming along with it, you'll see twig to these other diagnoses, especially if there's no nystagmus that comes with it initially. So this is where you have to look at other causes. Okay, so we're gonna move on. We're gonna talk about the episodic vestibular syndrome now. So again, this is episodes of dizziness where they last for seconds to minutes to hours to days, so whatever the episode is, but then in between completely normal, no symptoms of dizziness. Here, the timing and the triggers are very, very important to try to help sort it out. So again, here's a little bit of a breakdown about how you approach this. And the big differentiator here is this episodic syndrome triggered by anything, or is it spontaneous? And that's a big separator, because you look at the triggered causes of episodic dizziness, usually it's one of two main things. So either it's BPPV, which we're going to talk about, which is what the Dix-Hallpike tests for, or it's orthostasis. And then there's other rare things that it could be, but those would be the two big causes of triggered episodic vestibular symptoms. So we'll talk about those in a little bit. I'm not going to talk about orthostasis. You guys are way better at treating orthostasis than I am, but we're going to talk about the Dix-Hallpike and BPPV today. If you go down to the other group, spontaneous, there's a whole bunch of other things that enter there, and we'll talk about the differential for spontaneous episodic vestibular syndrome in a second. So, going back to the triggered ones, we're going to talk about this BPPV Dix-Hallpike thing. So first off, I'll try to answer the question, what is BPPV? The good thing about it is that the answer is an acronym, and the answer is in the acronym. So what it is, though, is the most common cause of episodic vertigo. So if you're going to learn about one thing, learn about this one. Its incidence about 1 in 1,000, so certainly very common. And if you look at the lifetime prevalence, depends on what study you look at. One study, the prevalence is about 2.5% in all, just if you took a sample of adults. But there was one study that went into a nursing home and looked at older patients, and they just did Dix-Hallpikes on everybody, and they found 10% of older patients had BPPV. So it's a big number. This is just all comers. They just went inside and looked. So something to keep in your mind all the time, because it's something that's very treatable. There are many causes, so degenerative, traumatic, after having inner ear disease. Sometimes we don't really know why. We're not sure about all of the causes, but certainly it's very common. And so what is it? If you look at the acronym, B is benign, meaning it won't kill you, but what I'll tell you is it certainly can be disabling and cause lots of morbidity, especially if it's not treated. It's paroxysmal, meaning that it comes in brief bursts of symptoms that usually last less than a minute. And some patients complain of symptoms for longer, so they feel nauseous and unwell, like I was talking about. So again, it's helpful to ask about how long did you actually spin for. It's positional, meaning it must be triggered by a head movement. So if they just were sitting there and then they all of a sudden got dizzy, that's not BPPV, okay? It's usually, for BPPV, the typical movements are looking up. So if they're hanging a picture or something like that, that's a typical one. Bending over, lying down or getting up, or rolling over in bed. Those are classic triggering movements for BPPV. We'll talk about why that is in a sec. And then the last part of it is vertigo. So rotational vertigo is the most common symptom, but as we mentioned before, some older patients can provide very vague descriptions. And I've had patients where I put them through a Dix-Halt bike and their eyes are spinning and they say, oh yeah, there it is, I'm lightheaded. And so again, you have to make sure that you don't put too much into it in terms of them saying lightheadedness or other causes or other descriptions of dizziness. Okay. Okay, one more brief slide on vestibular physiology. So you've seen this one before. You move your head one way, your eyes move the other direction. Turns out it's not just horizontal, it works in any direction. So you move your head up, your eyes go down, you move your head down, eyes go up. And how does that work? Well, you have 3 semicircular canals in your head on each side. So there's 6 total, and they basically work in these planes. So the horizontal canal works for your head moving left and right, but then the posterior canal and the anterior canal work on these kind of off-angle planes. So if you tilt your head back into the right side, that's the posterior canal on the right side. If you go forward to the left, that's the anterior canal on the left side. So these things are all oriented in specific planes. The only reason I want to tell you about that is because when you see the nystagmus in BPPV, it's going to match one of these planes if it's BPPV. So if it's in the horizontal canal, it'll look horizontal. And if it's in the posterior canal, which is the most common area, it's actually going to be upbeat and torsional. And I know we're all taught that upbeat is bad, but when it's upbeat and torsional in response to a Dix-Halt bike, that's actually what you want to see, and that's a peripheral cause for it, because it matches the plane of this semicircular canal, the posterior canal. So let me show you what it is. So this is BPPV in a small diagram. So what's inside here? These are called otoliths. They're actually part of a different vestibular organ that senses balance. We're not going to talk about that today. But the important thing to know is that there's little crystals that sit on these otoliths sit inside this vestibular organ, and they fall off over time. The organ degenerates and regenerates, and these little crystals fall off. If enough of these crystals fall off, and they sort of get together at the wrong time, and you move your head at the wrong time, what can happen? For some reason, well, it's not running. That's okay, we'll describe it. So what can happen is these crystals, if you imagine this whole inner ear tilting 90 degrees, these crystals will fall inside one of these canals, which is not a problem unless you move your head again. So then the patient sits back up, and the crystals will move from here and they'll fall down this way. So normally that motion is how you sense that your head's moving. But if you're not moving your head and these crystals are moving on their own just due to gravity, then what happens? Your brain thinks that your head's moving, and it makes your eyes move in a certain direction. And then if you're awake, you refocus and you get this nystagmus. So that's what happens in BPPV. If you get these crystals in the wrong spot, every time you move your head, the crystals are now gravity dependent, so they're going to slowly move. So usually it starts about 5 seconds after the movement. You move your head up. 5 seconds later, these crystals start moving, and then the patient starts getting vertigo, and you start seeing nystagmus. So this person has left posterior canal BPPV. I'll show you what it looks like. You can tell she knows we're going to do a maneuver. She doesn't look very happy about it. Okay? So we're going to have her moved over. We're going to align her head so that we're moving those crystals in that posterior canal, and you'll see what happens. So we're going to lie her down. Nothing happens right away, and then over time, the crystals start moving and she starts getting nystagmus. So this is classic upbeat and a bit torsional. It's torting towards that lower ear. And it comes on, it's pretty vigorous for a while, and then it slows down. Now as those crystals slow down and stop, the symptoms stop. If we sit her back up, she'll get symptoms again, but the nystagmus will go in the opposite direction. So you can see in slow motion, if you didn't see it before, you see how the eye's twisting. It's best appreciated if you look at the actual iris here. You can see it sort of twisting a little bit and also going up. And they're spinning the whole time when this is happening. Okay, so this is classic posterior canal BPPV. So what do you do for it? Well, you move those crystals back where they're supposed to be. And that's what the Epley maneuver is that this is this person with these little crystals inside the posterior canal. The Epley maneuver is basically, the first part is a Dix-Halt bike. You turn their head and you lie them down so the crystals move along the way. Then you get them to rotate their head to the other side. The crystals move a little bit further. You rotate the head again, the crystals move even further, and you sit them up and they drop out of the canal. And this is just a video showing you the exact same thing. So this is someone we're going to put into in this time turning their head to the right. And then we're moving, you see these crystals move down. and they get nystagmus associated with the crystals. And then we move their head the other way, and you can see these crystals moving themselves along the posterior canal. And then, again, they should see nystagmus again in that direction. And then what we're going to do is turn them over onto the side. And usually I support them better than that. I don't just twist their head. And then the crystals move even further. And then you get the patient to sit up, and these crystals should drop right out of there into the vestibule. Once they're outside of the canal, the symptoms are gone. Perfect. And you can actually test it. That's the best part about BPPV. You have somebody with symptoms, and you can create them nystagmus. You do the maneuver, you give them a minute or two to catch themselves, and then you do it again. And if you do it again and there's no nystagmus and they don't have symptoms, you know you've cured them. So you can send them out of the office and you've cured them that day. So it's great because you can test it right away afterwards. Perfect. There's not many things we can cure in medicine, so it's nice to have some. So the exam for BPPV, so again, the exam otherwise in BPPV should be normal. There's no vestibular pathology here except for these little crystals. So if you examine the patient and you see they're dizzy and there's nystagmus, you really shouldn't think BPPV. They shouldn't have nystagmus unless you put them through the maneuver. Okay, so if they have symptoms like this and you examine it and they're normal, then that's a good patient to test for BPPV. And the pretest probability gets higher and higher as you get older because the prevalence is so high. And again, it's even worth testing if the history is vague, because sometimes they just can't give a history that's very clear. So all my older patients who have sort of vague complaints of dizziness, I do the Dix-Flagpike in all of them, because you never know what you're going to find that way. And it's treatable in the office. Okay, that's posterior canal BPPV. There are other variants. If the crystals happen to migrate into other canals, you can get different variants of it, and you treat them differently. As you might imagine, you have to do different maneuvers to get these crystals out of there if they're in different canals. Again, if you suspect this is going on, I don't have a lot of time today to talk. You can look it up about the maneuvers or refer to someone who's an expert in it. Physiotherapists are often trained in this, and they can do other maneuvers to treat those. Okay. Why is it mostly in the posterior canal? It's a question that usually gets asked. It's just because the posterior canal is the most gravity dependent one. So if these crystals are going to fall anywhere, it's going to fall into the canal that's most gravity dependent. So that's why 80-85% of BPPV is posterior canal, and that's why you can treat most of them with the Epley maneuver. Okay, so we got through BPPV. We're speeding along here, so well, not that fast. We're going to get through these ones. So spontaneous episodic vestibular syndrome is now the same idea. Episodes of dizziness, they're well in between, but you can't find a trigger. And so here, the examination is generally less helpful because it's usually normal. The exceptions to that are if you're worried about TIA, there's stroke risk factors. If there's any residual neurologic exam findings, you might say, oh, they had a minor stroke. And if there's hearing loss on one side, then you might think Meniere's disease. But here, really, you're relying on history. And my differential diagnosis of spontaneous episodic vestibular symptoms goes from really scary things like TIA or cardiac arrhythmias or PEs and things like that, to more benign things, which is vestibular migraine, Meniere's disease, syncope, panic disorder. So in older people, unfortunately, the worrisome side of things is a little bit more common, and the less worrisome side of things is less common. Although things like vestibular migraine still exist in the older population, usually it will have started at a younger age. So most people don't start having vestibular migraine in their 80s. But they could have started in their 50s and 60s and then continue to have it as they go into their 70s and 80s. So something to think about. So how do you separate this? So I look at different symptoms and what they tell me. So if somebody has focal motor symptoms, like they get dizzy but they had dysarthria or hemiparesis, that's bad. But if they've had recurrent episodes for many years, that's less likely to be a serious thing, because if it was a stroke or TIA, they would have stroked by now, right? So the more symptoms you have over years, the better it is. The ABCD2 is just a stroke triage in terms of age, blood pressure, the symptoms, and whether people have diabetes. So it just helps us sort out who's at high risk for stroke. Visual symptoms can be good or bad. If they suddenly have a hemianopsia or diplopia, that's bad. But if they have a classic migraine aura and then they get dizzy, then that's good, because it's probably migraine. Again, cardiorespiratory symptoms, if they're anxious and they just kind of feel a little worried and then they get dizzy, that's good. But if they have an exertional trigger and they have chest pain, that's bad, right? So you want to sort things that way. Pain can be either one. If it's a rapid onset of neck pain, that could be a dissection and a stroke. But if it's a gradual building of a headache, that could be migraine, right? So it all depends on the character. Hearing change, again, if it's sudden all like that, you lose the hearing on one side, that actually could be a stroke in a particular area of territory, so that's bad. But if the hearing change happens over hours and there's fullness and pressure, that could be Meniere's disease, so that's good. And then nausea and vomiting and gait disturbance doesn't help you because it happens in either one of those. So that's sort of just a brief overview of how you can separate worrisome from more benign causes of the spontaneous episodic vestibular syndrome. I'm going to speak about vestibular migraine for 1 second because it's not that common in the elderly population. But basically what it is recurrent dizziness and headache. So you get headache and you get dizzy, and the headache meets migraine criteria. That's vestibular migraine. And again, the one thing I'll mention for vestibular migraine is usually in the elderly population, they'll have had it before. You just have to make sure you elicit that history. Okay, so I do have elderly patients with vestibular migraine, but they almost all of them started in their 40s, 50s, 60s with the symptoms. There's no great studies. It basically follows the treatment for migraine. So I won't talk about it in more detail. There's no specific studies on vestibular migraine, so it doesn't help us in terms of guiding treatment. Meniere's I will just talk about because it's fairly rare. It's actually much less common than vestibular migraine. It's severe vertigo, and it typically lasts for 2 to 4 hours when it happens, the vertigo. But it comes with oral symptoms, which are pressure in one side, usually one ear, fullness, and fluctuating hearing and tinnitus in one ear. Eventually it can involve other ears in some patients, but only about 20 to 50%. And it can start at any age, although typically it starts at middle age. But I've had patients where it started later on. And the key differentiating feature here is it's usually associated with a low frequency hearing loss, which is different than the high frequency hearing loss that usually happens with age. So we can use an audiogram to help us sort out what's going on there. I won't talk about treatments because it's not really the goal of the presentation today. And I want to leave some time for questions. But the final thing I want to talk about is the chronic vestibular syndrome. These are tough. So these patients have often been dizzy for many years, and probably a lot of the patients that you end up seeing. And in these patients, the rule is that it's usually a combination of things going on. There's a component of presbystasis, like we talked about. There's usually other pathologies, a little bit of a vestibular insult at one point they had, a little bit of a neuropathy as well. There can be overlay of psychiatric issues as well in terms of anxiety and depression. And there's often medication side effects that are contributing as well. So usually it's not just one thing. And my suggested approach, and this is just from experience, there's other approaches that might be valid, is for sure, number one, review meds. Make sure that there's not medication that you can't stop that might be contributing. And then I look at it and say, is there any low-lying fruit, meaning is there any causes of the episodic or acute vestibular syndrome there that I can treat? And the easy ones are orthostasis and BPPV because they're both super common. So I always look for those to see if we can get those treated. Then I look for any static balance pathology. So is there a visual problem we can correct? Is there a vestibular pathology that we can do some physio for? Is there proprioceptive abnormalities that we can help with? And then, of course, treat any anxiety, depression that you find, and then you can consider referrals if you need. And the goal here is, I always stress with the patients, we're not going to cure you and make you not dizzy 100%, but we want to improve your function. That's the goal of it. This is just a list of maneuvers that we use to try to determine if there's pathology in different areas. I won't go for it in detail, but you can look at it on your slides. I do want to mention vestibular therapy because this is very, very, very useful in treating most pathologies causing dizziness. The things that we do in vestibular therapy is 4 main strategies. One is something called VOR adaptation, where we promote CNS adaptation to a unilateral vestibular loss. So if somebody has vestibular neuritis, they've damaged one side of their inner ear. We do exercises to retrain the brain, to retune it so that it makes up for that vestibular loss. So that can speed and hasten recovery. Habituation is another way of treating, and habituation is basically somebody who gets dizzy with a certain stimulus. We just do it in a lower grade way and slowly increase the amount of stimulus that we expose people to, and eventually it doesn't make them dizzy anymore. So that's called habituation therapy. Substitution is, well, maybe your vestibular system got really hit. You got gentamicin, it's not working. So we can train people to use other sensory systems to sort of substitute for that. And then finally, vestibular therapists often will do cannula 3 positioning, so treating with BPPV. So that's an important thing we can get treated through vestibular therapists. And there's good evidence. So lots of good quality evidence that it helps in vestibulopathies, in anxiety-associated dizziness, post-TBI dizziness, in CNS disorders as well, in Parkinson's, MS, and SCAs, it can actually help a bit. And of course in BPPV it helps. So good evidence for it. it's better if you can figure out what the cause is. So if you figure out the cause where the deficit is, you can direct your physiotherapist to try to work on those deficits. But even if you can't find a specific pathology that's the number one, if you're like, oh, I think it's a combination of things, you can still consider it, because you can still improve baseline presbyostasis by improving posture control, muscle strength, VOR training. You can help all those little aspects of things. And so if you improve all those compensating systems, the symptoms can even improve, even if you don't know what the underlying pathology was or if it's not clear. Okay, so I think that's most of what I wanted to get through, and hopefully I've left some time at the end for questions. So again, my summary of my approach to dizziness is to understand how much presbyostasis is going on, to review medications to make sure they're not contributing, to determine the clinical syndrome, and if you can determine it, to target treatments which are based on the syndrome or the pathology that's underlying it. And if all else fails, you can always consider balance and vestibular physiotherapy, because it can help even in cases where you haven't determined the actual pathology. So we've sort of talked about that summary. Hopefully now you've got a little bit more caring about dizziness, and it's not just, oh, they're dizzy, we can't do anything about it. So at that point, I'll open up to any questions.